So right now it's about 9:03 a.m. So I know it's the afternoon for you all, or for most of you. So happy to be joining today. As you know, my name is Dr. Nikili Foon. I am located in, oh, sorry, just want to make sure that everyone can see the slides still, that it's up. Okay, wonderful. So I am located in Toronto, but where I work is in Mississauga, Ontario, which is where our innovation and research hub is located. And whenever we do presentations in our world, we also start with doing something called a land acknowledgement. So I just want to start by honoring the land that I'm located on, which has been the site of human activity since time immemorial. It is the traditional territories of the Huron-Wendat, the Anishinaabe, the Chippewa, the Haudenosaunee Confederacy, and most recently the Mississaugas of the Credit First River Nations. Ontario, where I'm located, is covered by 46 treaties and other agreements, and is home to many Indigenous populations and nations from across Turtle Island, including the Inuit and the Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, excuse me, are agreements to peaceably share and care for this land and its resources. So other Indigenous nations, Europeans, newcomers, and others were invited into this covenant in the spirit of respect, peace, and friendship. So we always like to start that just to contextualize a bit about where we are and to continue our journey as a healthcare system to work towards supporting the needs of Indigenous populations. So thank you so much for having me today. It's a pleasure to virtually meet you all. Looking forward to a really robust conversation. And let's start the show. So before I also start again, I just wanted to flag for folks, and I don't know if you may have seen this, but we recently published an article on a revised learning health system action framework. So this is a Canadian focused framework, one that was actually made with for and by an interdisciplinary team. So it was myself, a number of colleagues that are on this paper, some patient community and caregivers partners from across Ontario. And we came together to develop an actual refinement of our learning health system framework. So you'll notice, and for the sake of time, I won't go into every single piece, but you'll notice the way that we have framed the learning health system here is that we talk about the learning health system in a few key components. So one, if you look at the top of the image here, we talk about the learning health system and the process of actually using it. The requirements are that we need to have fuel and accelerants. So when I say fuel and accelerants, these are clean fuels. So like EV and hybrid, right? So we have things like leadership, patient and family partners, and so on and so forth. And these individuals help to move the learning health system along. And then you'll also notice in the very core of our learning health systems framework is patient, caregiver, provider, and community co-design, which is what this paper, the commentary that I'm going to be digging into with you today, is focused on, as well as some other components such as equity, excuse me, and then we have some moderators and breaks. So those are things that help to make sure that the system runs smoothly. I'm happy to share the link with you all on this paper after we connect today, but it'll hopefully be a really good additional piece to your arsenal of learning health systems frameworks. I know that everyone in different fields uses variations of a framework, so I'm happy to share that with you after the fact. All right, and just let me know if I'm speaking too quickly or if my slides aren't showing up. I'm happy to pause, okay? All right, so for today's chat, we're going to be focusing in on our commentary, which was called Positioning Patients to Partner, Exploring Ways to Better Integrate Patient Involvement in the Learning Health Systems. So I also want to take a moment to acknowledge all of my amazing colleagues who lent a hand in developing this commentary, especially my second author, Maureen Smith, who is this amazing patient partner who works not just with myself, but a number of folks across the province and country to really push forward the voices of patients and patients as partners to be actively involved and engaged in various aspects of healthcare and refining the learning health systems. We also have Sarah Green, who's our amazing partner from the US, who provides a nice US-based perspective on the learning health systems, and has also really helped to actually shape the learning health systems literature for quite some time, as well as Dr. Carrie Kaluski, who's this amazing scholar and staunch supporter of community-based research design, and really making sure that we work to embed community into every aspect of healthcare and the healthcare changes that we work to implement. And then finally, Dr. Rob Reed, who we call the godfather of the learning health systems in healthcare in Ontario. He's been leading the charge for years to refine and further embed a learning health systems approach into our health system, as well as in the US as well. So the image that you see here is something that was actually developed in partnership with my co-author, Maureen Smith. And as you noticed in the commentary, the first thing that you see as you start reading it is a quote from her, where she says, "I see patients, caregivers, and citizens role in the learning health system as one leg of a wobbly stool. There's no doubt that the lived experiences of patients, caregivers, and citizens are a pillar of the learning health system. We often hear the term embedded in the system. That needs to be explained to us in terms that are understandable so that we can see concrete examples of how it's operationalized throughout the process and provide further input in how we can move forward and provide our input in the process." So in talking to her about patient, caregiver, and provider perspectives of the learning health systems, she worked with us to develop this image that you see here. So if you notice, it's a nice stool, but it is a wobbly one, right? So we've got the shortest leg coming from patients, caregivers, and citizens. Then we've got a mid leg coming from health system partners. And then finally, the longest leg being that of researchers. So I just want to pause for a second and just check in with folks. So what are your thoughts about this image? And think about this image in relation to the work that you're doing. And feel free to, unmute yourself and share your thoughts on the image here. Or you can type your answer into the chat. So don't be shy.
I'm sorry, Nakia, for me, can
Yes.
you repeat the question?
Oh,
I just
sure.
stepped out, I'm sorry.
Yeah, no problem. So what I was saying was, consider the image in the context of the work you do, and let me know your thoughts on the image. And sorry, Sarah, I see you might have unmuted yourself.
Yes. Can you hear me?
Yeah. Yes. Hi, Sarah.
Great. So maybe from my perspective, being part of the Swiss learning health system, I think we all in the group can relate to that. Patients, caregivers, citizens. It's sort of, we should be much better in making them partner, also at the stage we are at, but it's always sort of a last thought, or still a last thought for a lot of people, I think, that work in at least what we see in the learning health system. And it's also a matter of what are good, like the question remains, what are good methods to include patients, citizens in a learning health system, and how to convey what a learning health system is to show them what they can actually benefit from, or how and why it would benefit them to be part of this. So these are just some thoughts.
Yeah, wonderful. Thank you, Sarah, for sharing. And I see Camille, I hope I said your name correctly. Have you written in the chat? I think that patients, caregivers, and citizens have the shortest leg because they are the least represented. Yeah, definitely. So I would agree with that. And thank you both for sharing your thoughts. So definitely the wobbliness of it is very much highlighting, as much as we talk about within the learning health system, that patients should be, play prominent roles within the system. Oftentimes that's not the case. And as well, by both comments, that oftentimes what happens is that they're not as embedded or engaged as they should be, or as we want them to be. So thank you so much for sharing again. So now what I'm going to do is I'm just going to go piece by piece through every section of the commentary and just flag a couple things for you. And then again, I like to to engage with folks as I'm doing these types of presentations. So I'm going to be asking for your thoughts as we kind of go through it. I know we've got some Q&A at the end, but I love to get some conversation going as I present. So the first section that you read through was, patients is more than just data donors. And what I flagged for folks here on the screen is that, oftentimes when we're talking about data, within the systems, we talk about it as quality performance measures, electronic medical records, or the other term that we use is electronic health records. I'm not too sure what terms are used in Switzerland. So whatever terms you use, they're all focused in on, what type of data are we collecting from patients as they access the healthcare system and they interact with clinicians. So oftentimes that can be, diagnosis, that can be things like gender identity, race, and so on and so forth. So those are kind of some of the pieces that when I talk about electronic medical records, those are some of the pieces that I'm meaning. And then healthcare outcome data. So, if you provide a client or someone with a particular medical approach, what is the outcome of that actual treatment, right? And what often happens is that when you look at the literature within specifically the learning health systems sphere, oftentimes folks say, well, we engaged patients and community by taking that data from them. However, what we do know oftentimes is that data isn't actually directly taken from their voices. It's our perspectives of them, right? So it's not us sitting down with a patient, a community or caregiver and asking, when you came into the hospital today, what was how were you treated? How do you feel as if you were treated? Okay, great. I'm going to take down that perspective. It's the institutional perspective of the patients and community and caregiver. And that's a completely different take on how things are done. And oftentimes there's a disconnect between traditional research funding approaches and patient, caregiver, and community identified needs. So what does that mean? Again, when you are going out seeking funding for a particular project and so on and so forth, oftentimes your funder, the research institute you're looking to get those funds from, they have a particular set of criteria that they require for you to touch and to hit in order to get that funding, and in order to, more often than not, to determine whether or not what you're looking to do, or if there's a particular healthcare initiative you're looking to enhance and refine. They have key goals, right? Key deliverables. However, when you actually connect with patients, caregivers, and community, those key goals and deliverables might be completely different. So one good example that I want to bring in is years ago, there was, within the Canadian context, years ago, there was a funding opportunity for, let's say, there was a funding opportunity for additional healthcare resources for the flu, right? So you go in, you come up with a really great grant, you write it, and then you say, we're good, right? We're done. However, when you go to the community and you say, we want to engage with you to figure out ways to advance work and support around flu vaccine distribution, what happens is the community says, no, I mean, that is important. However, what we're experiencing is, food insecurity, right? And we know that food insecurity has an impact on health, has an impact on health outcomes, and that's actually where we need the support. And without having had that conversation and having it so late in the game after you've actually submitted a funding request, there's that disconnect, right? So that identification of patients, caregivers, and community needs, it needs to happen at the very start. And that's where the disconnect can happen. Okay. So next section that was a part of our commentary was a lack of guidance to support PCC's understanding of the learning health systems, right? So again, let me just make sure. There we go. Oh, there we go. We talked about that one already. I'm just double checking. Sorry, I think there's a little bit of lag for me here. Apologies. All right, let's try this one more time. All right, limited involvement, right? Everyone can see the screen? Wonderful. Okay, so And talking about this one here is, again, the learning health systems, a lot of the literature that I'm sure you've all read, a lot of the courses that you've probably taken, there's always this, you know, desire to ensure that patients, caregivers, and community and citizens are actively involved in the learning health systems. However, when you do a deep dive into the literature, what you find is we talk about it, but we don't actually talk about how we're involving patients, caregivers, and citizens. What does that actually mean? So if we today were going to create, you know, we wanted to do an assessment about a particular, let's say, a particular approach to care, right, and engagement. How are we actually going to start the conversations with patients, caregivers, and citizens? Who are we going to? Who are the stakeholders? How do we get to those folks, right? And if you've never engaged with these folks before, how do we set the stage to make sure that, one, we start to build trust, two, that those folks actually feel as if they are active in and actively involved in the conversation, and three, how do we make sure that that engagement is sustainable? So not just let's start at the very beginning, let's have you come in, give your 2 cents and leave. How do we make sure that the conversations that we begin actually continue on for the duration of whatever work we're doing, right? So the other thing too is, a lot of times, because patients, caregivers, and citizens are a part of the conversation, and we say they're a part of the learning health systems, that doesn't necessarily mean that they know that they're involved in a learning health system, right? So there's a lot of organizations and institutions out there that use aspects, or they actually come from a learning health systems approach, but they don't frame their approach as such, right? So folks will be engaged, they'll be connected, but they actually won't know that they're in a learning health system, or they won't actually really understand what that means, right? And if folks don't understand what they're doing, then they can't really actively participate in the journey of helping to enhance the system, right? And one issue that comes with that lack of understanding is that there's actually a lack of common learning health systems language, right? So the ways, for example, that we talk about the learning health systems in Canada may be different, and oftentimes is so, than the US and other parts of the world, right? So because of that lack of common language, that also leads to a lack of common conversations, right? And when I say common conversations is, you know, talking to you amazing folks in Switzerland versus talking to amazing folks in other parts, there can be disconnects, right? And that disconnect can have an impact on participation with PCCs, and I say PCCs again, patient caregivers and community, as well as within the system and other folks that are part of it. And then the other thing too is to consider is, oftentimes when we are working with patients, caregivers, and citizens, particularly within the literature, the focus is often on this kind of one-dimensional patient, caregiver, citizen, right? So this universal individual or individuals that are a part of the system. And as we know, there's no such thing as a one size fits all, right? Every patient, every community, every citizen is going to come with their own set of questions, concerns, and experiences. And those questions, concerns, and experiences are going to play varied roles in how they interact with the learning health systems and how they actually participate in the system. So if we are starting as researchers from a place of let's have this one size fits all approach, we are missing a lot of the conversation, and we're also missing a lot of the ways that we can actually refine the learning health systems to better support the people that we're intending to care for. So I'm going to stop there for a second. Any questions about what I just mentioned or raised from folks? And again, feel free to unmute yourself or to drop it into the chat. So I'll give it a couple seconds. Okay. All right. So onwards and forwards. So.
Maybe I just have
Oh, yeah.
something really
Yes,
quickly.
sure.
I just wanted to know kind of what your suggestions were as far as like the common language, or I mean, even like knowledge products, so that patients, caregivers, or individuals from the community can meaningfully engage. Do you recommend that we maybe co-create this or co-design some of these things collectively, so that, I don't know, because Anna and I often talk about this. I mean,
Yeah.
at one point we were just like, maybe we just go to the fair and start asking people, like, how do you receive
Yeah.
science information?
Yeah, no,
But
that's a great question. Yeah, no, that's a great question. So definitely would recommend doing that, right? So starting from, again, because there's no universal, again, and when I say there's no universal learning health systems language, that's of right now it's 9:23 a.m. again in Toronto. So as of 9:23 a.m., there is no universal language when it comes to learning health systems, right? So from one person, one institution to the next, everyone's going to have their own definition and their own kind of ways in which they showcase and move through the learning health system. So if you are working with patients, caregivers, and citizens, the best way to start off like the journey with them is to make sure that everyone's on the same page when it comes to language. So would definitely recommend, sitting down with folks and saying, hey, you know, this is how we frame the learning health system in the work that we do. Does this make sense to you? Right? So when I talk about leadership, right, and as I mentioned earlier in the image that I shared in terms of learning health systems action framework that we've developed, when we talk about leadership, we define it, right? And we say, does that make sense to you as a patient, caregiver, citizen? Do we need other examples? Is that the best wording that we can use? Or should we modify the wording to make better sense? Right. So we're actually doing some work on with that framework. So that framework that I shared earlier is one that your team, yourselves here could use and could refine and modify for the work that you do. However, the way that it's framed doesn't necessarily mean that it's going to be understood by patients, caregivers, and citizens. So we're actually currently working on developing a companion to that framework so that the terminology that we use is modified with the help of patient caregivers and citizens to make sense for them, right? So definitely agree, checking in with folks, asking questions, which oftentimes seem pretty, simple, right? So we're all here, we all have some great knowledge about the learning health systems. However, that's not necessarily the case with patients, caregivers, and citizens. So always great to be on the same page when we're having conversations, especially with folks that we want to deliver support and care to. So I would definitely recommend connecting with the folks on the ground to ask them if this terminology makes sense and how can we change it to better suit your needs. So good question. Yeah, and that's where the knowledge translation comes into, right? So you all are experts, so I'm certain that you can do it. So thank you for that. Any other questions or comments from folks? All right. So then I'm going to move on to the next section here. All right, so missed opportunities, right, for PCC involvement in the learning health system. So again, as I mentioned in the commentary, so once we get PCC involvement in the learning health systems, wonderful. However, what often happens is PCCs are often siloed, right? So you might have a bunch of folks that are in one particular area providing feedback on, excuse me, like performance maintenance, right? You might have folks in another section talking about X, and these folks often rarely actually interconnect with each other. And what does that mean? That means that sometimes what will happen is that a lot of great learnings from one particular realm of healthcare gets lost, right? And it doesn't actually get transferred over to another. And if we're thinking about the learning health systems, it's a continuous cycle of research and practice informing research and so on and so forth. And if that siloing continues, we're missing an opportunity to further enhance the system and to get additional really great feedback from folks. And then the other thing too, and I mentioned this earlier, right, is that oftentimes PCCs, they don't know that they're in a learning health systems based institution, right? So So it's great to have a learning health systems institution there, but if they don't know that they're working in it, how can they actively be a part of the conversation and work towards building and refining services and resources for those that need it most? So it's really important that if folks are framing and if healthcare systems are framing themselves as being informed by a learning and working with and through a learning health systems approach, that they actually explicitly say that, so that again, everyone's on the same page, folks know what they're doing, and they also understand how the learning health systems approach actually is informing care, right? Okay. And then finally, we always like to end off commentaries with what can we do to move the dial forward, right? So we, the last few sections of the commentary are very much of this is what's missing, this is what's not happening, these are the gaps, right? So the way forward section was very much a what can we do to move things forward to advance patient, caregiver, and citizen involvement in the conversation, and what are some things that institutions can consider and should consider when they're actually engaging patients, caregivers, and citizens in the learning health systems. So one major thing, and we as a team, we always talk about the importance of, yes, data collection is great. However, why are you collecting this data, right? So a lot of hospitals, healthcare institutions, and so on and so forth, we always like to collect data, right? So data is great. However, if we're not actually saying we are collecting this data because of, and we are going to use this data to do this, and this data will help inform X. If we're not doing that, we're just collecting things and then we're hoping for the best, right? So as someone who is, I'm also the health systems, the health equity research lead at the Institute for Better Health. One thing I like to say when we do collect data, data without context is just a bunch of numbers, right? So it's important, again, to get patients, caregiver, and citizen involvement and to get them at the table to have conversations that when we are pulling this information and this data, what does it actually mean, right? So for example, the best example of the learning health systems approach recently, and I hate to bring up COVID again, but here we are and talking about it. But within the Canadian context, what we found was that a lot of populations, folks were impacted by COVID in different ways. However, what we noticed was that there were some racialized populations. So when I say racialized, I mean folks that identify as being South Asian, African, Caribbean, and Black, Latino, and so on and so forth. We noticed that some racialized populations were actually uh, getting COVID at much higher rates than the general population. So if we looked at the data alone, right? So we just looked at the data, we found that, for example, folks that identified as South Asian were getting COVID at much higher rates than other folks. We would say, okay, well, that means that there's got to be something going on. Maybe it's something genetic. We got to dig into it, right? And maybe we got to quarantine folks that identify as South Asian. However, when we're using the learning health systems approach, right? Going through, talking to patients, talking to caregivers, citizens, digging into, the actual evaluating the data, digging into the context, having deeper involved conversations, what we learned was that folks who identify as South Asian, one, they lived in multi-generational households. So what does COVID love? COVID loves to be around a lot of people, right? What we found was a lot of folks that identified as South Asian, they were actually frontline service providers. So folks that were working in, places that we needed the support, right? So that would be, support workers, um, folks that delivered food, folks that interacted with people on a regular basis. And what does that mean? The more interactions you have, higher risk of COVID, as well as, not everybody had access to a vehicle, so they're taking public transportation. Again, the more interactions that you're having, the more at risk of COVID and exposure you are. But if we just looked at the numbers alone, we would say this particular population seems to have a heightened risk of COVID, and we need to maybe isolate them. But because of that context, getting that feedback, we were able to actually further understand some of the reasons why certain populations were acquiring COVID at higher rates, and then work with our healthcare organizations and community health centers to, one, increase awareness about how COVID was spread. Two, once we had the vaccine, actually come up with a specific approach to disseminating the vaccine. And three, coming up with community ambassadors. Those were individuals that lived in various communities that can go in and have conversations, share news and knowledge, teach folks about vaccination and the benefits to help to lower those numbers. And with that learning health systems approach, actively having folks involved, we were actually able to significantly reduce the number of folks that had COVID and mortality rates within that population. So that is why it's important to, when we collect the data, that we actually dig in and work with folks to understand from the community what is going on. And then again, you know, when we talk about involving finally patients, caregivers, and and citizens in health systems activities, what does that actually mean? Are we actually asking them to participate, or are we, and if we are, when are we asking them to do that, right? So are we asking them at the start, the middle, or the end? And we always strongly recommend that you do not ask folks at the very end after you've collected all the information, you've done all the work, and then you ask patients, caregivers, and citizens to then chime in, because at that point it's too late, right? And the other thing too is you're building trust as you go along, right? So you don't want to go at the end and say, let's have your feedback now. You want to start at the very beginning, and you want to make sure that that conversation is sustained over time. And it's just the beginning of work that you're doing with patients, caregivers, and citizens. So yeah, so those are the two key aspects, suggestions